Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Dr. Choll Kim, a Harvard Medical School graduate who completed his residency at UCSD Medical Center and a complex spine fellowship at the Mayo Clinic. He is currently in private practice in San Diego, California, where he specializes in minimally invasive spine surgery. In this episode, we discuss a number of topics, including what made him leave the world of research and pursue a career as a surgeon, how the field of minimally invasive surgery has changed over the 20 years he's been practicing, and how future technology, like augmented reality, will change the surgical landscape. Enjoy the conversation. Dr. Kim, thank you so much for taking time out of your day to join us here on Checking the Vitals. I really appreciate your time.
Thank you for having me.
Absolutely. It's my pleasure. So I like to start off with a similar question especially with our surgeons that we talk to. And that is, what is it that made you want to work in healthcare to begin with?
I think I've probably thought about the field of medicine since I was a child, probably because my parents tried to convince me since probably I was in the womb. And of course, they have a doctor and my brother's a lawyer. So from the Korean immigrant story, that's a very common scenario. But there was a time when during undergrad, I had to really think about what it is that I want to do for the rest of my life. And initially, I went into a PhD program. So I do have a PhD in molecular biology.
Oh, wow.
But I got that before I got my MD. And during that time, I was thinking I'm going to be a scientific researcher. And I still am fascinated by the scientific process. But about 2/3 of the way through, I realized that I really like being around people more. And I want to participate more directly in helping people. And it just seemed like a work environment that was more suited for me. So I decided for real to go into medicine while I was a PhD student, toiling in the laboratory. I still do a lot of research, not bench research, but It was a conscious decision that I made kind of further along down my academic career. It was after I did my undergrad at UCSD and then started a PhD program at UCLA. And it probably was a good idea because I think I'm much more suited to be a physician and a surgeon than a bench researcher.
I think that's very interesting that you went from a field that was sort of solitary in some ways, research, especially bench research. You're sort of working on your problem and trying to solve your problem or trying to, discover whatever you're trying to discover. But it really is you and the problem. It isn't you and other people with a problem to solve. And I think it's very interesting that you realized that that was your passion and then sort of backward engineered a career, a very lucrative and successful career out of that into sort of orthopedic surgery. So when you made that decision, did you at that point say, okay, I sort of have to finish the semester or maybe even just stop immediately and start applying to med school? Or how did you go about that process of switching sort of further downstream than most decide to become a surgeon?
Well, it was an easy decision because it wasn't a one or the other scenario. Because at that time, I thought that I could still be a physician and still do research, but I could do research that's much more closer to human disease. So for a long time, I was planning on becoming an academic physician. And although I'm primarily a surgeon, that experience was really helpful because there's nothing like having to do a thesis project where you start with nothing and address a problem and a question and try to answer it for the first time.
Yeah.
And I think that experience helped me to become a minimally invasive surgeon because I'm sure most of you know, most spine surgery is still performed through traditional open techniques, and they tend to be very large, bloody, painful surgeries. And that experience helped me take a problem. Traditional spine surgery is big, open, and bloody and painful, to figure out how we can make it less. And that experience let me, I think, become a good minimally invasive surgeon because that process of switching over from being trained as a traditional open surgeon to becoming a minimally invasive surgeon when that field really didn't exist required all the skills that I learned during my PhD program. So even though I don't do bench research, I'm really glad I spent the time doing that, that I had that experience because it's really hard to think the way you do after you do a thesis if you've never done a thesis before. It's a 5-year project that you don't know if it's going to ever end and what the end is going to be, and there's a lot of uncertainty. And had I not done that, I probably would have been reluctant to make the leap of trying to forge a path toward a whole new area of spine surgery. Probably would have more stuck to what I knew best and could do well on a consistent basis. Whereas by becoming an invasive surgeon, there was a period of time where I had to figure things out on my own, and that can be very challenging and daunting at times, especially when you're taking care of patients actively.
That is what makes it high stakes in my mind, right? If you were in a lab setting where it was, just training and you weren't impacting any live patients, I feel like it's a much lower stakes scenario, but you're actually working with real live patients. Around what time was this that you started to sort of really dig into the minimally invasive spine surgery? Like what years did you start to get into that?
That's a good question. I actually made that decision during residency when I was trying to decide what subspecialty I wanted to do. So I did my first spine rotation. I scrubbed into my very first spine case. It happened to be a big open surgery, revision surgery, because we're at the university. We're taking care of all the most challenging, complex patients, a lot of failed back surgeries. And I looked into the wound and I was just shocked at how gruesome it was. And I thought to myself, how can a person survive a surgery of this magnitude? And the human body's amazing. They do. But I immediately thought to myself, okay, spine surgery is probably where I should do it, what field I should go into if I want to forge something new, because there's got to be something better than this traditional open surgery. So I made that decision during residency, and it drove my decision to go into spine surgery because that was the one field that was still lagging behind, like knee and shoulder surgery or knee and hip surgery. That field where they do lots of arthroscopy and other minimally invasive surgeries, that was already there. But the thought of doing endoscopic surgery in the spine, for example, or little mini open surgeries in the spine with all the nerves and the spinal cord, people weren't really thinking about it that much. Only a very small number of really kind of far-seeing, innovative surgeons were starting to do that. And I'm really good at not being the first person, but the second wave, where once I realized that the first wave, they're kind of legit, jumping onto things that clearly work, but needs fine-tuning to make it applicable to patients. So I just happened to be at the right place at the right time in many, many ways.
That's super interesting to me that you sort of give credit to sort of like knee surgeries with the sort of breaking ground in orthopedic space as far as minimally invasive is concerned, but no one had really done it for spine yet. When you started to sort of pick it up and run with that banner, if you will, or maybe, as you said, there had been some that had done it and proven it could be successful, and you sort of helped in that second wave. So I'd imagine that if this was in your fellowships, it would have been around the early 2000s, right? Because you were Harvard Medical, and then you went into your fellowships and residencies after that, correct?
Correct. The fellowship occurs after your internship and residency program.
Right.
So it's like an extra year on top of your surgical training. And I happened to go to the Mayo Clinic, which is a huge open practice with revision surgeries. And you can just imagine, it's the Mayo Clinic in Rochester, Minnesota. There's literally, like, at that time, 85,000 people in the entire town, but it is the biggest medical center at the time in America. So people would send all their most complex cases. So that fellowship was considered probably the most open, most multi-level, most challenging surgery, and the training involved was all open. And I think it was helpful. So after that, when I came back, I immediately started thinking about how I could incrementally start making big surgeries smaller and smaller and smaller and smaller.
Right. So when you say that was all open, or those surgeries were all open, do you mean actual, it wasn't minimally invasive? You were opening up sort of the whole sort of back of the patient to be able to access the spine?
Right. So instead of making like 2 to 4 little incisions to try to get to 4 sites, traditional open surgery is to make one long incision down the middle and spread everything open so you can see all 4 sites all at once.
Oh, wow.
And you can see if you have the spinal cord and the nerves as part of the surgical field, and you need to protect those vital elements that you want to be able to clearly see. But turns out it's not necessary to see everything. You need to know where you are in three-dimensional space, but you don't need to actually see it with your naked eye. And that's probably been the biggest change, because most minimally invasive spine surgeries actually are doing the same thing as the traditional open surgery. The difference is how you get to the surgical target site. Do you make one big incision and just strip everything off all the bones and see everything all at once? or you make multiple incisions to get at each of the target sites and only look at one target site at a time.
So can we talk a little bit about that, if you don't mind?
Yeah. So for example, I'll give you a typical surgery. If we did a fusion, which is a very common surgery, and it's a surgery that most people are afraid of. We call it the F word. And everyone's so scared to death of that word fusion, and they should be.
Yeah.
That's a surgery that involves essentially at least 2 surgical target sites, but we make a big midline incision and strip all the muscles off the bone, and we put in 4 screws and an interbody spacer or cage, a bunch of hardware in there. But you can do all that by making 2 separate incisions. And it's a total pain because it's twice as much work, and you can only see like a part of the anatomy with your naked eye, but not the rest. So you have to picture in your mind where everything is. But in the end, you still put in the screws in the exact same place, you put in the cage in the exact same place, and you still decompress the nerves in a very similar way. And the goals of the surgery are all the same. So if you take an x-ray, it almost looks identical to the 2 surgeries. But if you look at the patient, the amount of damage to the back muscles, it's just night and day.
Yeah, I'd imagine the from scar to recovery period is way shorter for minimally invasive, just because you're not sort of cutting all of the back of the patient and peeling everything back and removing the muscles, and you're not having to put them back. They are naturally where they always have been and are where they are used to working. So that body doesn't have to necessarily heal that section. That's just a guess, though. I'm sort of asking, is that why?
You're exactly right.
Okay.
So there's a name for that. When we do surgery, we always create what we call collateral damage.
Okay.
So like the skin incision is collateral damage. You have to cut the skin, even though the skin's not part of the problem, to get to the spine, right? So when you do a big midline incision, I'll give you an example. You have to detach the tendons at the level above your fusion. And when you do that, the tendon never heals for some reason, because some things in the body, when they get injured, they don't heal. Mm-hmm. And if you injure the tendon at the level above your fusion, guess what happens to the adjacent level next to a fusion? It breaks down. It's called adjacent level degeneration. Yeah. So we see that when you do a minimally invasive fusion, among other things like bleeding and postoperative pain and the size of the scar, one really important thing is that it decreases the risk of adjacent level degeneration. And a lot of patients that have been thinking about fusion surgery, that's one of the first things that they bring up, because when you have adjacent level degeneration, you may need another fusion surgery. Yeah. So think about that. And that occurs pretty consistently, like 20% of the time over a 10-year period. So it's still, the majority of people are doing fine, but there's a 20% risk that you may need more surgery. If you can get that down to much lower, of course you want to do that surgery. On top of the fact that there's less bleeding, so you're less likely to need a blood transfusion. There's less postoperative pain and disability, so you don't stay in the hospital for 3-4 days. You go home either the same day or the very next day. And then there's a whole recovery period where people need to get back to their lives. And nowadays, missing a month of work is a big deal.
Oh, yeah.
So there are numerous advantages to doing minimally invasive surgery, as long as you're properly trained and you have enough experience and you can do a good minimally invasive surgery. It's better to do a good open surgery than a bad minimally invasive surgery.
Oh, sure.
So it's critical that that the minimally invasive surgery be done well. And that's easy to do through training. And there's a lot more technology that's available today than it was when I first started doing this 20 years ago. It's still very difficult, though, and that's probably the main reason why many surgeons still do open surgery. The learning curve can be daunting.
Well, and I would imagine that, and maybe this is a little unfair to say, but surgeons who are coming up through their, I would say, more formal education now, whether it's, med school, probably residency is where you would start to get some familiarity with minimally invasive now, I'd imagine. But for surgeons that are, I would say, more established, it is something that is relatively new or was new when they were already practicing. So when they went through school, they would not have learned that technique. And I'm sure there is a way, although I do not know what it is, that surgeons who were not, didn't learn it while they were in school can go learn it. But I don't know what the mechanism for that education is.
Yeah, my guess is that what's happening in spine is very similar to what's happened in many other specialties. So it turns out that, at least in orthopedic surgery, many of the innovations in minimally invasive techniques occur outside the academic setting where residency training occurs. So you start out by knowing that most surgeons are still doing traditional open surgery. So therefore, most academic surgeons that run residency programs are still doing traditional open surgery. And those surgeons then get trained as an open surgeon, and they go out and start their practice.
Yeah.
And they're going to naturally stick to what they feel comfortable with. And everyone else is doing open surgery. So most of the initial transition occurs after your training. So you have to find surgeons that have a practice, they're already out there, they've completed their training, and they still yearn to continue to improve. Most surgeons aren't like that. Most surgeons, we've spent 10, 20 years getting trained, honing down a set of skills, and now we just want to apply them without lots of guesswork. And I get that. I just happen to have one of those brains that are wired to constantly, it's never good enough, I'm constantly wanting to do better. But most of medicine is about first do no harm. So don't get all creative on patients. Be careful, and much better to do something that you know how to do, even though it may not be the best way to do it, as long as you do it in a consistent, reliable, reproducible way. So the transition is probably going to occur in the spine, just like it occurred with shoulder arthroscopy, laparoscopic cholecystectomy. It's going to all occur post-training through surgeons wanting to continue their medical education and going to conferences and learning from other surgeons when they're already in practice. So that's one of the reasons why the adoption of new technology in medicine, especially in surgery, occurs very slowly.
I would imagine that, and correct me if I'm wrong, because you're actually working in the space successfully. I'm just on the outskirts sort of looking in. But I would imagine that is sort of by design, because you want people, and sort of like you said, it's better to do an open surgery that you know you can do well than practice a minimally invasive surgery on, a technique you haven't done much, right? Because you can do it well open. It's repeatable. You can do it over and over. You can help multiple people. So like, I'd imagine that the adoption of new, whether it's technologies or techniques, is slow on purpose in the surgical space, because you do want repeatable results and you do want to help the most people possible. But I will say, I do know that there is this natural need to do better and have better outcomes. And there's a lot of things that sort of push that forward, but I'd imagine that it's by design that it's slow.
I think the fact that it's slow is not necessarily a bad thing, but from my perspective, it's slow not by design, but by just circumstance. So if by circumstance, surgeons in America, went to training intermittently over the course of their career and were expected to learn new techniques in a kind of formal manner, that we could change the field much more rapidly, but still maintain that level of safety. But because there's no mechanism for, legitimate training once you get done with your residency program, it's unnecessarily takes too long. So, that's just my perspective.
Sure.
But you're absolutely right. No matter how it's done, it's more important that transition occur safely. And if it has to occur one surgeon at a time, so be it. And, that's how I'm participating. I give a lot of lectures and I give lots of presentations and I publish papers and things like that, where I'm trying to reach out to a lot of surgeons. But the majority of the surgeons that convert from open to minimally invasive surgery and do it well, I've taught in my one-to-one program, where one surgeon comes and visits me. They watch me do the surgeries all day, just stand in the OR and they see me do the surgeries. And then the next day they go to the cadaver lab and practice that surgery start to finish over and over again until they are familiar with all the steps. Because in the end, it's still the same surgery. It's just getting there. It's not like you need to learn new surgical skills. You just need to have a new perspective. So right now it's one-on-one, and eventually there'll be a critical mass of minority surgeons that are MIS, but that number is big enough that more and more residency training programs will have these minimally invasive surgeons, like the way I was 7 years ago, where they're training the residents in a more formal way. So you're absolutely right. It should be done carefully, and until something else presents itself that allows us to make that transition safely, it'll probably stay like this for a long time.
Yeah. And I do understand that you have worked in that sort of academic space. I wouldn't call you an academic surgeon by any means, because you do have a practice that you actually see patients all the time, but you do have sort of close ties to, well, at least one college there in Southern California. Are you able to sort of, in that capacity, guide people towards, or I should say surgeons, guide potential new surgeons towards the minimally invasive route?
I do that through the skin to skin program and all the lectures, but
Mm-hmm.
my guess is that if I was still at the university today, I'd be much more effective in training the residents that are in training and the fellows to go out and, as their first job, be minimally invasive surgeons. When I first started, the minimally invasive field was so new that the training program was lagging behind. So
Sure.
it's only been recently that I really understood what it takes to train a surgeon to become a minimally invasive surgeon in a safe and effective manner. So
I'd imagine that a lot goes into that.
a lot. It's multifactorial. And right now, if it's not done in a training program, the best surgeon to train to become a minimally invasive surgeon is a really excellent open surgeon. You do not want to train a mediocre open surgeon to become MIS, because they're going to become a poor MIS surgeon.
Sure.
You want to take somebody that's already an excellent open surgeon and they've already have lots of experience. And these are the ones that actually make the transition, I noticed.
Yeah.
And they're motivated to take that step. And I now insist that they just do one technique at a time.
Mm-hmm.
They do it exactly the way they watch me do it, without one single change for 5 cases. I get on my hands and knees and beg them, please don't change one thing. Because it turns out surgeons are really creative.
Yeah.
And I'm sure you're not surprised, but we're really singularly minded. Like, we think we know everything. So when I was first training people, even the visiting surgeons, they would say, well, I'd like to do it like this. Is that okay? And I would say, I think so. And I would find out later that that one little change would discombobulate 5 steps later and make the whole case very difficult. So my understanding of what it takes to properly train a surgeon to become a minimally invasive surgeon is a lot different now than it was 15 years ago when I was at the university. So
Sure.
like everything, that is evolving as well, the training.
Yeah. And I'd imagine everything will evolve as time moves forward. Everything's going to move that way.
The equipment's even better too.
Yeah. It's interesting that you would say that the really good open surgeons are the ones you look for to become excellent minimally invasive surgeons, because they do seem to be those, I would call them lifelong learners. I mean, you guys, and when I say you guys, I mean surgeons in general, you are in school for a long time. So I definitely do understand if you've been in school for, you're 35 and you're just now finishing school, that you have learned everything you need to learn and it's time to go out and practice. And I understand that mentality, but it seems like the people who you want to bring into the minimally invasive field are the ones that, even though they've been learning their whole life up to that point, they are not satisfied with that. There's always more to learn for them. And those are the people that I like to surround myself with, because they're the most fascinating people, I think.
I never looked at it like that. I think you're right. To be an excellent open surgeon means not only that you're technically excellent, but you tend to be the type of person that's constantly trying to get better.
Yeah.
I was thinking that being a spine surgeon is actually kind of technically demanding. It's sort of like playing golf. You can't just go out there and start hitting the ball. You have to practice and you have to build your skills and your technique. And with the technology today, minimally invasive surgery is still very technically difficult. If you play golf, it's the difference between playing with a cavity back iron versus a forged blade iron. All the pros play with forged blade irons, but if you've ever tried to hit a forged blade iron, you'll realize it's really difficult. But once you get good at it, you can hit the ball much further and you can shape the ball like the pros do. But until you learn how to hit a blade, it's gonna be difficult.
Yeah.
So generally speaking, golfers that play with blade irons, they were previously really good cavity back iron players. They were already good golfers, and that's why they made the transition. But I think you're probably more right. Those players probably are the type that care about getting better and are constantly looking for ways to improve. And going from open to MIS is just that next step. I didn't think about it like that, but I think you're probably more right than the technical thing. It's more of a personality trait than a
sort of
skill.
a personal philosophy.
Right. But you can't be a klutz.
Oh, no.
To be a spine surgeon today, it's so technical. It's amazing.
Yeah. Well, even to be an open minimally or an open surgeon, not minimally
Even open
invasive.
surgery
Yeah, it's
requires
got
a
to
high
be.
degree of technical skill.
Yeah, well, and I imagine that being a minimally invasive spine surgeon has all of the difficulty of being an open surgeon, but a layer of complexity because you can't see everything you're touching, right?
Exactly.
So how do you solve for that? And what sort of technologies are you using now as opposed to when you sort of first started this in the early 2000s that has helped sort of solve for the not being able to see what you're doing as far as like where you're screwing the screws in, where you're putting the cage in, that kind of stuff?
It is amazing how fast the technologies progressed just in my career, which is just spanning just 20 years since I finished my fellowship.
Yeah.
So when I got out of fellowship, the way you put in a pedicle screw is you'd look down and find the entry site. You drill a little starting hole. You take like a gear shift probe that you force down the hole to create a path for the screw, and you put it in.
Mm-hmm.
And when we went to MIS, we still did it like that, but instead of having the entire spine open, we would only have a small portion of it open. And then when we realized it's really difficult to tell where you are just by looking at a small piece of the anatomy, it'd be like trying to figure out what an elephant looks like by only having a magnifying glass. You can just imagine how hard it would be to figure out what everything is just by starting with a magnifying glass. So we decided, we'll use intraoperative imaging like the pain guys do and interventional radiologists. That's basically intraoperative live x-ray. So we have a little opening, we kind of know where we are, and then we have an x-ray machine that has an x-ray picture, and those two together kind of told us where to put the pedicle screw. And then shortly thereafter, we could make the incision smaller and the imaging got better. And today, we don't use x-ray. We use what's called navigation and intraoperative 3D imaging. Mm-hmm. And we even started using robots. So now imagine you have a three-dimensional picture of the spine, sort of like in your car.
Yeah.
It's basically an intraoperative CT scanner or an intraoperative MRI.
Okay.
You take a picture of the MRI and you put it up on the screen, and you can drive the instruments looking at that screen. Very similar to how you use navigation in your car.
Yeah.
And now you have a picture of the spine up on a screen, and you have an instrument that you can maneuver around like the car to the right street, to the right location. And now you can, without having to directly look at the anatomy, know where you are. So I now do surgeries, and if I don't have intraoperative imaging, I will cancel the surgery. I'm almost like McCoy in Star Trek. You know how McCoy in Star Trek always says he's a surgeon?
Yeah.
But he's not. He's an interventional radiologist, because all surgeons of the future are going to be interventional radiologists. McCoy would never open up the wound. He just takes that tricorder and waves it around you.
Yeah.
And he can see inside there and know what's going on. And he'll even do surgery like that. Well, we're getting closer to that. So it's a complete mind shift.
Well, yeah, with like the gamma knife technology and stuff is getting very close to some of that. I mean, very rudimentary versions of it, obviously, but that stuff is
that's a classic example of future technology where you don't even have to make a skin incision when you use the gamma knife.
Yeah, it's wild.
It is wild.
So I'd love to ask you why you will cancel a surgery if you can't get that sort of CT level imaging. And is it, my theory would be that that is directly linked to outcomes, or you've seen it maybe in your surgeries that having that imagery is such an advantage for both you and the patients that you don't even want to do it without it. That would be my guess, but correct me if I'm wrong.
That's exactly right. The most simplest way to look at it is that no matter how you do the surgery, you need to know exactly where you are at all times.
Yeah.
When you do traditional open surgery, you do that by exposing the surgical target site and just looking down there with your eyeballs. If you're not going to make a big incision and expose the surgical target site so that you can know where you are in three-dimensional space, that has to occur through intraoperative imaging. So if I don't have an intraoperative imaging system for the surgery, I would have to do it open to do it safely.
Yeah.
And unless it's an emergency, I would rather just wait and reschedule the surgery for a time and a place where I don't have to do it open. And there's still times where you have to do open surgery, but if you don't have to do open surgery, it's better to do it minimally invasively. But that requires that you have the ability to know exactly where you are in three-dimensional space without physically looking at it with your eyeballs.
Yeah, which I'd imagine as, things are progressing, that technology is getting better and better. And you sort of talked about the progression from X-ray to more of an MRI / sort of CT scan. that is sort of an always on approach to it instead of an X-ray. I'd imagine you just take a picture at one time and then you sort of move, take another picture, move again, take another picture, set the screw, or however many times you have to do that. But you're taking a lot of X-rays, whereas with the CT or MRI scan approach, it is sort of an always on. You can sort of always see where your instruments are.
Exactly. It would be like the difference between using the Thomas guide. I don't know if you're old enough to remember this.
I remember
Thomas guide. So imagine using a Thomas guide to get someplace that you've never been before. You would be driving, and then you'd look where you were, and then every once in a while you'd have to open it up, and if you're traveling far, you'd have to flip the page and go to the next section and see where you are. Versus when you use the navigation in your car, you're just driving and it's just updating as you go. And it's very similar. So before I was using computer navigation, I did exactly what you said. I would take a picture and know where I was. I'd do some work and I'd take another picture and go, yep, that's where I think I was, and good. And I would take it intermittently. And there's a couple of problems with that. One, instead of having a three-dimensional picture, you have a two-dimensional picture. So that gives you a great limitation. And two, every once in a while, you think you're somewhere and you actually made the wrong turn and you don't realize it until you check again. So you can make a lot more, there's a lot more potential to make mistakes. And it's just physically cumbersome to have a C-arm intraoperative X-ray machine in the field while you're operating. So oftentimes we won't take enough shots because when they comes in, you have to stop operating.
Yeah.
And then you take the picture and then the machine comes out and then you start operating again. With navigation, you don't do that. You're just operating, and you may have to pause every once in a while to look at something, but you don't have to pause for a machine to come in. It's just live, and you just look. All it takes is that you look up. So the technology for that is tremendous. It's tremendous in terms of its rate of advancement over the last 5 years.
And I'd imagine that simple change alone has made surgeries obviously safer, but also faster, because you're not having to wait so long for the X-ray and then, okay, that is where I thought I was, let's continue. You're sort of just always doing the surgery.
Yeah, it is. It's way faster and way more accurate too.
Yeah, that's awesome. So, and I would imagine that being, as you, I think, self-identify as one of those like lifelong learners, and you're so connected to minimally invasive. I mean, I do want to talk about how you started a society for minimally invasive surgeons. So I would imagine that when you're at conventions with this group that you started, you're talking about those new advancements in minimally invasive surgery.
Exactly. I started the Society for Minimally Invasive Spine Surgery way back in like 2008 because we would go to these big national meetings, and there's a small group of us that were doing minimally invasive surgery, and we'd all sit together. And we'd be hearing a presentation and we'd look at each other going, why would they do that open? And the other person would be like, I don't know. It's like, I don't know either. And we'd want to get up there and say something. And that small group got big enough that I finally just said, hey, why don't we start our own society so that we can give our talks and we can get up there and share our experiences and teach each other things. And, back in the day, there weren't that many societies. So there was a small group of us and we grew very rapidly together. Today, almost every big national meeting has a very large minimally invasive component. So I don't think you necessarily need a minimally invasive spine surgery society any longer because it's part of the big societies. But even still, we're kind of like the minority of people sitting at these conferences. But it is really important that we don't just work in a silo. Every time I go to a conference and I meet one of my colleagues that are doing minimally invasive surgery, I learn so much from them because it's a rapidly evolving field, and a lot of it is based on experience. And if I do 200 to 300 cases a year, that's not the same as me sitting in a room with 10 other surgeons that each also do 300 cases a year. Now we've combined the experience of 3,000 cases instead of 300 cases, and the rate of learning just goes up exponentially. And now with the advent of things like internet communications, podcasts, webinars, the pace of that improvement has increased exponentially. So it's a really exciting time in spine.
Oh, I'd imagine it's a really exciting time for almost every surgical specialty, and I'll tell you why. I would wager that, and you may have already been doing this, but I'd imagine that now or soon to now, you will start to see sort of remote learning for surgery. So, and let me give you an example. Someone was interested in learning. They've already graduated, they're in the residency and fellowship, and they want to learn minimally invasive now. They're one of those lifelong learning surgeons. They could, with technology we already have, watch you do surgery in a way, anywhere in the world, they could watch that. And then they would, I'm assuming they wouldn't then just go jump and do it themselves. They would need to get practice in a safe setting, like a cadaver setting. But they wouldn't need to go all the way to Southern California. I don't know why they wouldn't want to, but if they couldn't for whatever reason. So I'd imagine that that's going to be sort of the next big evolution in at least training post, residency and fellowship.
I'm really glad you brought up that point, because remember we were talking about the obstacles to adoption and the whole learning curve, and there's no formal mechanism by which to train somebody.
Yeah.
And I think that's going to be a really important next wave in how we help each other get better and better and better. So I'll give you a classic example. I have a skin surgeon. He flies out and he spends 2 days with me. He watches me do the surgery, and then we go to the lab and we practice. Well, in my mind, that is just one step in a long-term journey of becoming a minimally invasive surgeon, because you never get to be like Buddha. You're always like learning.
Yeah.
So imagine now you have a mechanism by which that surgeon that's already been to visit you continues to get experience without having to travel all the way here by simply just virtually being in my OR.
Yeah.
So I hope that in the very near future that I will be able to have a system where you can put on a virtual headset and be home, but feel like you're standing in my OR looking over my shoulder. So there's at least 2 systems that are already out there that I should probably jump on, but it's just one of those things. It's like item number 553 on my list of things to do, and it's still not there yet. But I envision that there's going to be a lot of training initially as a follow-up to more formal training and ongoing training where you can gain experience virtually. And I'm really glad you brought that up. I suspect the technology is already there or soon to be there, where those goggles are going to make you feel like you're in the room.
Yeah. So I'm super interested in virtual reality and augmented reality, but all my friends are talking about like the gaming aspects of it. I'm sort of bored by that. I'm more interested in, and probably because I do this podcast, I'm more interested in specifically augmented reality. And I'll give you a scenario as to why. Right now, when you're doing surgery, you're looking at a screen, and that is sort of telling you where your hands need to move. But your hands are working on the patient or working on a machine that is then working on the patient, right? And to me, the disconnect that you have to be able to build up between where you're looking and then, what you're doing with your hands was very difficult for me to grasp when I was playing with one of these robots. When I was very fortunate, I got some time on one. That was so difficult for me. And I would say decent. I'm not a professional sports person or whatever, but like I had pretty good hand-eye coordination, and that was so difficult for me to grasp. But if you had augmented reality where you have glasses where you can see the room around you, but when you look at the patient, you then see sort of what your CT scans are always showing. And then you could look directly at the patient and sort of use your machine while looking at the patient. I sort of see that as the next logical step with at least augmented reality that I'm super excited about. And I would love to see, and maybe get some feedback from someone who actually does that job, if that is something that people who do the job might even be interested in.
I totally agree with you. I hope that in my lifetime, I'm going to see that, because here's the way it looks now. I'm operating on the patient.
Yeah.
I'm looking down a little hole, and then intermittently I'm looking up on a screen, a separate screen, sort of like you do in your car.
Yeah.
But if you're driving a car, you wouldn't drive just looking at the navigation screen. You spend most of the time looking at the road itself.
Right.
Because at least today, the navigation is not accurate enough. And that's exactly the same case in medical navigation and robotics. It can be up to 2 millimeters off. So you still need to look at the wound most of the time.
Yeah.
But do you need to look up at a screen and interrupt your visual gaze to do that? No, you can, if you have the right goggles, for example, you could just keep looking down there, and you can either overlay the computer navigation image, or make it disappear and just look at the anatomy, or you can have a hybrid view, which is augmented reality, where it's a mixture of what you're really looking at with a layer of kind of like a translucent picture of other stuff. It's almost like you're looking through the skin and the muscles all the way down to the bone when you're operating, even though the skin and muscles are there. So I think that's going to happen in the not too distant future. And that's going to be another incremental step in allowing surgeons to do minimally invasive surgery much more effectively, much more efficiently, and much more safely.
Yeah. I mean, because ultimately that's what everybody wants, whether it's patients or hospital CEOs or surgeons. Everyone wants better outcomes. And how we achieve better outcomes, maybe we have some disagreement there, but everyone ultimately wants just better outcomes.
Totally agreed. That's our goal. And in every other aspect of the world pushes us to be better. And medicine is unusually slow in that regard. We just want to be good enough. But as soon as we can demonstrate that efforts at being better should be ongoing and continuous, and the technology starts being presented in a way that you can do that, I think it'll be a very easy switch. And I think we're going to see some dramatic improvements in our surgical outcomes, because there is a big technical component to it.
Yeah. So there's a lot that obviously goes into making a surgery successful for the surgeon. Things that you're doing, technology that you're using, and techniques you're utilizing. What else goes into making a surgery safe for the patient in the room?
So on top of all the technological imaging advancements that we've made, we also have made significant improvements in the way we monitor the function of the nerves. So imagine I can see everything, but I also want like functional feedback. So we use this system called intraoperative neuromonitoring. So it's a way of keeping track of the nerves. And if I get too close to a nerve, it will get irritated, it will fire, and the neuromonitoring system will alert me through beeps that I'm too close to the nerve. Because remember, nothing is perfect in medicine and surgery. The navigation system could be up to 1.5 to 2 millimeters off. You're also working like sub-millimeters next to nerves. So it's not enough just to know where you are using navigation. And sometimes the blood's in the way. You also want functional information. So in my OR, the amount of technology that's in there seems overwhelming, but it's all the pieces that let me do the surgery most effectively. Because even with that, you don't get perfect results because the spine is so complicated. So in my OR, I have a whole set of specialized tools, all the minimally invasive instruments. I have a 3D imaging machine with computer navigation, and soon we'll have a robot to help hold things steadily in one position without, slipping off, et cetera. And then we have a functional system called neuromonitoring that gives us yet another piece of information about whether or not I'm too close to the nerve, or, for example, let's say I realign a spine. So a spine's been bent over for a long time, and we're going to straighten it out. Just the process of straightening out a spine sometimes will pull on a nerve because of the change in distance. And that's not something you can see in imaging. So that's a whole nother layer of technological abilities that help you monitor the safety of the surgery and the effectiveness of the surgery. So just like if I don't have navigation for an elective surgery, if I didn't have neuromonitoring, I would also reschedule the surgery to a time when I had it, because in the end, I want every single advantage that I have available to me to do the surgery in the best possible way I could. And if you're a professional athlete, it's easy. You'd be very uncomfortable going out there with a piece of equipment that you've never used before in a major game. Like if I was on the Masters tournament and I lost my golf clubs and I had to borrow somebody's, I'd be really scared that I'm not going to do as well, and I probably wouldn't. So the OR is very different than I think what people used to think. We used to have, it was all on the surgeon. We had to just use excellent surgical technique, and all we needed are some pickups and some scissors and some basic tools, and we didn't get the job done. Today, it's like a Formula One race. You need a good driver. You need a computerized car where every tire is being monitored, the brakes, the suspension, everything, as well as a team behind you that's looking at computer monitors saying, the rear right tire is starting to get hot. You better slow down on that turn, et cetera, et cetera. So it's much more of a team effort, much more technologically advanced. I suspect that's going to happen in a lot of areas of surgery, not just spine surgery.
Yeah. And again, I think that that only makes the outcomes more successful, which everyone wants. So I do agree that I think every type of surgery, and I do think, neurosurgery and orthopedic surgery have been quick to adopt things like intraoperative neuromonitoring and things like that, because I think it is very conducive to their surgical uh, practice. But what surgeries they're doing, it does a good job of monitoring that spinal cord, and also it serves as a great replacement for wake up tests, which slow down surgeries. And we sort of talked about, speeding up surgery is only going to make things better for the patient and the surgeon. So I definitely can see, and it may not be intraoperative neuromonitoring, it may be something else for cardiac surgery or whatever, but I can definitely see those kind of things coming into the OR and turning it more from a what I think of as like the surgeon, and you sort of talk to this too, the surgeon being like the hero in the room, the one person who can fix everything, to more of a team approach, like the Formula One analogy that you gave earlier. That's great. So, Dr. Kim, I want to first thank you so much for your time today, but I do want to close with one final question. And that would be, if you were talking to someone who was in med school, but had not yet decided on a surgical sort of technique they want to focus on, or like a residency program they want to go into, what would your pitch be for them to consider minimally invasive orthopedic surgery?
I would say that right now, if you want to go into minimal invasive spine surgery, make sure that you have the personality type that where you'd have a diagnosis of something that we call the syndrome of chronic dissatisfaction. I've been accused of having that problem. I tell people I actually have the disease of CANI, C-A-N-I, continuous and never-ending improvement. But it kind of depends on the perspective.
Sure.
You have to be the type of person that it's just never good enough, and you're constantly looking for something better, and you're always trying to improve. Because if you're not like that, it will be very difficult and frustrating to go into spine surgery and keep up with the large group of people that are changing the specialty dramatically. I suspect that most people are already like that. They just need to ensure that that's not taken out of them during their medical school and residency,
Sure.
which currently that's what it tries to do.
Yeah.
The residency training program tries to knock you down and rebuild you up to be very, consistent and boring, because that's the safest thing to do.
Sure.
And you have to have the mentality that, okay, I can take that, but when I'm done, I'm going to continuously try to improve and little by little try to change things in a safe, incremental manner. And I think most of it is just kind of a personality trait that you nurture instead of trying to suppress. So that's probably the most important thing. And then the second thing is that it's a specialty that is very demanding on your physical body. So you have to be the type of person that can stand there for a long time and in one position without getting too fidgety, and plan on staying really healthy if you want to stay a spine surgeon a long time, because spine surgeons have all kinds of musculoskeletal problems, especially neck problems.
Yeah.
But foot problems, elbow problems, back problems. So those are the two big pieces of advice that I would tell people thinking about going into spine surgery today.
Excellent. Well, Dr. Kim, again, thank you so much for your time today. I appreciate you being here on Checking the Vitals.
Thank you so much. This is great.